Hello, and welcome back to the ASCO Journal of Oncology Practice Podcast. This is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. In early 2016, the NCI and ASCO joined together to sponsor a Teams in Cancer Care Delivery workshop that was intended to expand the scientific base for teamwork and team science in cancer care. Clinicians and team science researchers gathered together to propose an application of team science to a specific problem in clinical oncology, and these teams eventually put together manuscripts that were revolving around a particular case-based elaboration of their scientific principle of team science. And these are being published in a special edition of the JOP this month. Joining me to talk about his project is Dr. Raymond Osarogiagbon, the director of the Multidisciplinary Thoracic Oncology Program at Baptist Cancer Center in Memphis, Tennessee. He's going to talk about his paper titled Deploying Team Science Principles to Optimize Interdisciplinary Lung Cancer Care Delivery, Avoiding the Long and Winding Road to Optimal Care. Ray, thanks so much for joining me today.
Thanks, Nate. Thanks for the invitation. I'm glad to be here.
How did you end up getting involved in this NCI ASCO Teams project? What drew you to that?
Well, we thought this would be a good idea because we have been very passionate about the concept of improving healthcare systems by increasing the use of interdisciplinary methods to deliver complex cancer care, especially in lung cancer. And we actually had an ongoing Patient-Centered Outcomes Research Institute sponsored study in my institution that was looking at this very problem. So when we caught wind of the NCI ASCO Teams in Cancer project, we were very interested because we thought there was great synergy between that and what we were trying to do.
Could you just briefly take us through the case scenario that you included in the manuscript to illustrate why this can be such a problem?
Yes, Nate. Our case is actually a real-world case. It was actually a real example of the problem. So we had a middle-aged woman who was in excellent health, business executive, presented for an routine annual physical, gets a chest x-ray that shows the presence of a tumor in her lung, the right upper lobe, and so she quickly gets sent by her primary care doctor, who was the one who ordered the x-ray, to see one of the specialists who provides care, so a medical oncologist. And the medical oncologist arranged for a CT scan to be done, which confirmed that there was not just a tumor in the lung, but also multiple bilateral lesions. The PET CT scan gets done that shows all of these lesions to be PET avid. The medical oncologist arranges for a biopsy, which confirms that it is an adenocarcinoma, and then leaps to the conclusion that this is stage 4 disease with bilateral lung involvement and sends the patient on for systemic chemotherapy. The patient winds up receiving multiple different regimens. Ultimately, the patient's family gets her into a multi-D clinic that takes a look and says, wait a minute, this patient's performance status and the picture and the history of her experience is quite different. There's a big discrepancy here. We know we're in a granuloma endemic part of the country. We probably need to confirm her state histologically because it's never been done. So she gets a biopsy of some of these lesions. They all turn out to be non-caseating granulomas. So you see the passage of almost 3 years from initial diagnosis, a lot of intensive systemic therapy, and she winds up getting curative intent surgical resection of the primary in the right upper lobe. Turns out to be a T2A N0 non-small cell lung cancer for which she had gone for 3 years expecting to die. We thought that this illustrated the challenge of lung cancer delivery when it is fragmented and the opportunity for collaborative team science principles to be used to improve the quality of care.
Before we get to sort of illustrating what could have been done differently for this patient, getting into some of the tenets of team science that you discussed in your paper here, you talk about forming what you call a real lung cancer care team, as opposed to the kind of traditional care that this patient underwent, something I think you refer to as serial care delivery. So can you take me a little bit about what you mean by that?
Yes, I think it's very important to distinguish between a term that we all use, multidisciplinary care, and this idea of real cancer care teams. I'm trying to push a concept here that distinguishes between the anatomy and the physiology of interdisciplinary care. So at one level, we can say we are multidisciplinary because we have, a medical oncologist talking to a surgeon, talking to a pulmonologist, talking to a radiologist in some fashion. But on the other hand, there is the physiology, which is, well, how well are they actually interacting to the patient's benefit? So the principle here is that a real functioning team has a clear understanding of their task interdependency. We understand that we have a common mission and that we need each other in order for that mission to be accomplished successfully. We interact with each other in a constructive way. We respect each other's opinions, and we work collaboratively towards the patient's greater good, which is our ultimate mission. So the idea of a real team here is actually talking about the aspects of the interactivity between the key elements that you have to have on a team. How do they cooperate with each other? How do they inform each other? How do they communicate? What is their individual and collective understanding of the task at hand and where that task is supposed to lead to? On the other hand, the serial care model is sort of an extreme example of how we can have multiple components that on paper might form a team, but if the team does not recognize itself as such and does not actively acknowledge the common shared goals that they're working towards, then they will not truly function to their potential capacity.
I think this concept, this so-called shared mental model of the optimal patient care and what the team is supposed to be doing is a really simple concept, but actually I think it's a really powerful tool. And I think that's kind of what you're talking about here.
Yes, absolutely. The degree to which we understand what we're trying to achieve and that understanding aligns together is the degree to which a team is going to function. Predefining what tasks and goals are is a key component. Having the same understanding. So when I say we want curative intent therapy for this patient, we want palliative care for this patient, everybody on the team has to have the same picture in their mind of what that is. It's very important for us to understand that really this tangled mess that is the community of lung cancer patients needing care really are asking for certain things, and we have to have common understanding of that. They want, for those who have it available to them, they oftentimes want to be rid of their cancer permanently, i.e. a cure. For those who don't have that available, they want to be able to get good quality life for whatever is left. And if that proves to be with extension of life expectancy, that would be a goal that people want. And those who don't have the option of curative intent therapy have the option of pathways of care. And it's important for the team to be able to understand the need to triage patients into these pathways and do so as quickly as possible, because timeliness of care is a highly patient-centered outcome that patients have explained to us is very, very valuable to them in the face of what might be a life-threatening illness. Even though, Nate, as you and I probably are aware, we don't have objective evidence that, more timely care translates into better survival for patients. In fact, the evidence is somewhat to the contrary. But the reality is that if we are in the understanding that what we're trying to do is serve the patient as best we can within the boundaries that we set for us, timely care is definitely a highly valued patient-centered outcome as well.
No, I absolutely agree. So for the particular case that you have here, how would being a part of a real lung cancer team initially potentially would have led to a different treatment?
So if you take our case presentation, the patient had, yes, a chest X-ray and a CAT scan arranged by one of the first responders, who then sent the patient to a therapist, a medical oncologist, who does not have the ability to procure tissue himself, almost automatically introducing delay in the process of care. That's one early example of where things began to go wrong. The other examples are that the clinician involved, who happened in this instance to be a medical oncologist, seems to have done just enough work to convince himself of the value of his modality of treatment. So there was a disconnect between the patient's performance status. It was a completely asymptomatic patient who seemed to have disease here, there, and everywhere. We think that if some of the other specialists had been involved early on, they may have put a little bit of a pause in the flow of events and said, wait a minute, there is a need to confirm stage here, because we know that a PET-CT scan can be falsely positive. And so all the PET scan is doing is pointing you to a target lesion to get a biopsy of so that we can establish stage. So that was never done. The other examples of things that went wrong were that when the patient's family instigated external opinions at two different sites, at one site, the need for a biopsy was recognized. Unfortunately, the lesion that was biopsied was exactly the same as had been done before to establish the diagnosis. So it was not a staging biopsy, unfortunately. So we think potentially that if you had had some of the coordinators involved as well, maybe communication would have been closed loop, more accurate, more precise, telling you what we know and what we don't know, and maybe the optimal lesion to have obtained that biopsy from. So these are some examples of how we think better team coordination might have helped this patient out.
And so going forward to places that don't have already this tight-knit real team structure, what can we do to improve the formation of teams where they don't currently exist?
And that's where team science can really help us out, Nate, because a lot of these principles have been tested and well established in other parts of the economy, whether it's the finance sector, whether it's the military, whether it's aerospace, whether it's the aviation industry. These principles have been established, and sometimes in healthcare, we act as if we are so special, our problems are so unique, that existing ideas don't really serve. But I would argue that actually we are not special. We're just another part of the economy, and that what we have failed to do is rigorously use existing knowledge to our benefit. So the idea is, let us, identify that these people who are interacting and providing care are actually on a team. We're on the lung cancer care delivery team. Who are the key actors? Identify them clearly. Bring them together and say, okay, guys, what is our goal here? Let us agree. From your perspective, let us bring these ideas together and let us come to some kind of agreement. Let us also work out the way we're going to communicate effectively with each other. And that effective communication has to be precise. So when I say precise, it has to be specific about who, what, where, when, how. It has to be timely in order to be of use in, improving patient outcomes and their experience of care. And it has to bear the broad goals clearly in mind. There are clearly obstacles to achieving these ideals, not the least of which are finance, economic obstacles, not the least of which are also time obstacles. Who has time to do that is sometimes what's here. And so there is a need, as this work develops and as we're in a transformative part of healthcare reimbursement now, that we test these principles, and where they're validated, that we actually embed them in our reimbursement model so that members of the team become more and more incented to actually collaborate to the grand mission.
So, Ray, thank you so much for talking to me today about this important topic and your great paper in the JOP.
Nate, thank you so much for your interest. I can tell you I and my team that collaborated on this work are greatly honored to see how interested you and the journal have been. Thank you very much.
And I also want to thank all our listeners out there who joined us for this podcast. The full text of the paper is available at ascopubs.org/journal/JOP, published online September 30th, 2016. Don't forget, you can also read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journal's mobile app, available in the iTunes Store and Google Play. This is Dr. Nate Pinnell for the Journal of Oncology Practice, signing off.